Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Hello, welcome to today's presentation, Understanding Lower Back Pain, presented by Dr. Rajiv, Saigal, neurosurgeon with UCSF and Washington Township Medical Foundation. Dr. Saigal is an associate professor and neurosurgeon scientist at the University of California, San Francisco. He is board certified by the American Board of Neurological Surgery. Please welcome Dr. Saigal.
Hello, welcome. Thank you for attending this seminar on health and wellness. Today we will be talking about minimally invasive options for treatment of low back pain. I want to start by saying that most cases of low back pain do not need surgery. And although I'm a spine surgeon here talking to you today, I want to give you some general background about what's common and what are common non-surgical treatments. And then we're going to talk about some surgical cases. So, first of all, the most common cause of low back pain is musculoskeletal strain. Here you see three examples that are very common. On the left of your screen, you'll see somebody working, a construction worker who's in a less than ideal posture, bending forward. Then in the middle, you'll see an athlete lifting weights. In this example, we would call that axial loading, where there's a lot of weight overhead, so the back is bearing the weight of that. And then on the right is a very common scenario as well, the parent who lifts their toddler or young child over and over all day, every day. And that in itself can be a cause of musculoskeletal strain. Most of those, again, will not need surgery. So what do we do for the average patient that comes in with low back pain? You know, this is going to affect practically everyone at some point in their life. And for most people, we're going to start simply. Sometimes if you have what we would call an acute exacerbation, meaning things are all of a sudden worse, you may need to just take a rest and avoid whatever are the triggers that are making your back pain worse. For working in a computer or looking at a tablet or phone, where we all spend a lot of our lives these days, one thing that's important is to have good ergonomics. So you don't want to always be in the bent forward position looking down. That strains your back, it strains your neck. So first of all, on your desk, whether it's at home or at work, I recommend trying to set up your screen so that you can sit comfortably and look straight ahead without looking down or looking up. A neutral position is really what's best. And then similarly for using a phone or tablet, try to hold it in a way where you don't have to bend forward all the way. And those type of simple ergonomic changes can often go a long way. Then what if a patient needs some sort of treatment? There are a number of good options for non-surgical treatment. Acupuncture is one of the few things that has passed randomized controlled trials as a treatment for low back pain that often does make people feel better. Physical therapy is a great option, often some combination of stretching and strengthening under the guidance of a professional physical therapist can make patients feel better. There's a concept of something called traction, which basically is just pulling the spine gently apart and unloading the discs and joints that can help. And people can actually do this themselves at home with something called an inversion table, which effectively allows them to hang partially or mostly upside down at different angles. And shown here is one example of a type of inversion table that's commercially available to you to buy at home. And then lastly, I'm personally a big believer of electrical stimulation therapy. This is a TENS unit you see on the bottom right. And those are stickers that one can place over areas that cause pain. I personally recommend these for many of my patients with neck or back pain, but they're also used in other specialties for other areas of the body as well. And basically these devices plug into an electrical controller that gives some pulses, and that can minimize pain transmission and help patients feel better. As a next step up, some patients of course will need medications, and there are a number of choices for that. We frequently use anti-inflammatory medications. There are over-the-counter options like ibuprofen. There are topical gels and creams. For example, there's a topical one called diclofenac that's very popular. There are local injections as a kind of a next step up in invasiveness. I personally don't do these, but many of our partners do. And a patient may get, for example, a local steroid injection right over an inflamed nerve root or the sac of nerves, and that may help them feel better. And finally, there are neuropathic pain medicines. These are medicines that focus on the transmission of nerve pain that can also be used, and of course that would need to be prescribed by a physician. Okay, so when is back pain surgical? Here are some examples. Number one would be if the nerve or spinal cord is compressed. Number two, if a patient has suffered a trauma. That's not always, but sometimes it's surgical. If a patient has a tumor, again, sometimes, not always surgical, but certainly you'd want to see a physician for that. And lastly, sometimes spinal deformities. And we're going to talk about each of these in the context of minimally invasive options. So let's just broadly talk about minimally invasive spine. This is a field that's totally taken off in the last few decades. And shown here is a graph with the number of papers on this topic published each year. You can see starting in the late 80s, you might have just a couple examples, and then really in the 90s you start seeing more of the papers. And by the 2000s, this starts to grow exponentially. And now minimally invasive spine is thought of as a very popular technique, a way to treat many of the same conditions, but potentially with less collateral damage. I'm going to talk about that more as we go forward. So what is minimally invasive spine surgery? First of all, the goals are the same as traditional, what we would call open spine surgery. So goals in general, it may be to decompress a nerve that is pinched or compressed. It may be to stabilize the spine if the spine is unstable, or maybe to realign the spine if the spine has some abnormal alignment, whether it be from a traumatic fracture, a deformity, or a tumor causing a misalignment. Minimally invasive has the goal of achieving these same surgical goals, but with less collateral damage than if one has a big open case where you really have to push the paraspinal muscles and the other soft tissues to the side during surgery. Okay, so let's look at some case examples. These are patients that I personally have been involved with their treatment. So first I'm going to present to you a somewhat complicated patient that I treated with a pretty tiny surgery. This patient was 33 years old. He had a history of early onset scoliosis surgery. This was done when he was a child, and he actually had already been fused in childhood from T10, that's the 10th thoracic level, to lumbar 4. And he had a body mass index of over 41, so that means it's above the target weight that we consider if we consider all patients. And this patient had a work-related injury, and all of those were contributing to mid to low back pain. This patient had no pain until this work-related injury occurred, and he was moving packages at work, and that caused the back pain. It was constant in the mid-low back. It was up to 9 out of 10. And importantly, for this particular procedure that was available to him, his pain was worse with flexion, meaning bending forward. And that implies a particular type of pain that I'm going to talk to you about. So he had to stop working because of the injury. He had tried physical therapy. He had tried an opioid medication called Norco. He had tried Tylenol. He had tried a lumbar steroid injection. He had tried a facet block. All of these different types of treatments, non-surgical treatments, and unfortunately none of them worked for him. When I examined him, met him and examined him in my clinic, I found that his legs were weak. We have a 5-point grading scale, and out of 5 possible points, most of the muscles in his bilateral lower extremities or legs were about 4 on that 5-point scale. But he was limited by pain. He didn't have any imbalance and his reflexes were normal. That tells me something as well about him as a spine surgeon. So before we operate, we like to get preoperative imaging. These are x-rays that showed his old implants in place, again, that had been placed many years ago as part of another spinal fusion down to the level of lumbar 4. Now, his MRI scan showed something subtle. You see that circled in yellow, and I'm going to point it out. There's a little bit of disc degeneration between this level, which is called L5, and this one, which is called S1. You can see this disc is a little bit darker than the other ones, and a whiter color on this type of image is fluid, which is good. When the discs get darker, it can suggest that they're somewhat dehydrated, and they don't have the same amount of shock absorption and same amount of normal movement that you can get when fluid is normally in place in the disc. The other thing to point out is what we call a modic change, and that's what you see is this bright white spot at the top of S1 and at the bottom of L5. And those bright white spots are thought to be associated with degenerative disc disease, when there's some local inflammation around these parts of the bone. They're called the end plates. And we think that in patients with chronic low back pain that's worse with bending forward, their pain might be coming from a nerve that is giving feeling to this area. That nerve is called the basivertebral nerve. So there's a relatively new procedure. It's called basivertebral nerve ablation. Basically, we're ablating or effectively burning that nerve that goes to this location and sends pain signals. In patients like this, we think they might have chronic pain because that particular nerve is firing too much. So even though this patient had had a very big surgery many years ago, I could treat his problem with something very small and targeted. So what I did was basivertebral nerve ablation at these two levels, L5 and S1. The incision is very small, just a few millimeters, and basically we insert a special type of needle down through the spine and to the target location. Inside of that needle, we pass a radiofrequency probe that's going to heat up and burn, the medical word is ablate, the nerve that goes to that location. And here in this x-ray, you can see that radiofrequency probe located at the target. So I did that at those two levels. The surgery is actually pretty quick. It can take about half an hour or less on the operating table, and the patients go home the same day. So then I saw him back in clinic 6 weeks later, and he was remarkably better. He said he felt 80% better than he had before the surgery. He was able to walk into the appointment where before he would have had to stop twice just because of pain. He was able to do his activities of daily living at home, like washing dishes. He could walk stairs better than he used to be able to. His back pain was previously 9 out of 10. Now he was rating it at 4 out of 10. Now I do want to point out that's not 0. And we almost never with any surgery will achieve a target of 0 out of 10 back pain. But what we want to do is improve it enough that we affect the patient's quality of life. The patient was doing pool therapy at home. He was able to lose weight as a result, and his strength had even improved because he was no longer limited by the pain. So that's one case example. This technique of basivertebral nerve ablation has been studied in larger populations of patients. Shown here, I'm showing you some data from a randomized controlled trial that studied this in a large number of patients. And they compared the patients at baseline before they got anything to several years later. And what you're seeing on this graph is something called the Oswestry Disability Index, or ODI. In this case, a higher number is worse. So at baseline, these patients had an average ODI, or disability number, of 42.8. So they were fairly disabled. And when they came back and checked them 5 years after having this type of nerve ablation, their disability number had gone way down. Now it was averaging 16.86. So a significant improvement that lasted up to 5 years after this one-time surgery. So then you might ask, well, how many patients actually benefit from this? In this particular study, it was around 4 out of 5 patients said 75% or more pain reduction. 47% of those said 75 to 100% pain reduction, and 34% remarkably said 100% pain reduction. So, and that again is with a minimum of 5 years of follow-up. So that's a pretty nice result. Again, this is one randomized controlled trial, but that was a pretty significant result, and one of the data points that made me think that I wanted to start providing this procedure for my patients. Okay, now let's talk about a different type of case example. This is a patient who has something called a spondylolisthesis. A spondylolisthesis is a medical word for a slip. Basically, one level of the spine is shifting forward or slipping on another. And what you can see in this yellow circle is that this level, which is L4, is shifted forward about ½ centimeter on L5. And in many people, that will cause back and leg pain, as this patient had. She was 65, and she came to see me with back and right leg pain. She said the back pain was about 5 out of 10, the leg pain was also about 5 out of 10. And on that same disability scale, she rated her disability as 39 out of 100. And I asked many of my patients to draw on this type of diagram where exactly their pain is. And you can see here, she's drawing it, that it's in the low back and then it's going down the outer part of the right leg with these X's and dashes. So when we see that on an MRI scan, which is done while the patient is lying down, I'll generally also add a standing x-ray with the patient bending forward and backward, because I want to see if there's any dynamic movement at this level. If so, that further cements that this is the cause of their low back pain. And this patient indeed had that. When she bent forward, this slipped even further compared to when she was laying down for the MRI. As another preoperative data point, we asked her, how bad is your overall health if you consider this and everything? And she scored that 40 on a 100-point scale, with 0 meaning the worst possible health. So she did not feel good generally because this was bothering her so much. So what I did was a minimally invasive fusion. I only fused this one level. This type of surgery can be done with 2 small incisions, one on each side of the low back. And through those tiny incisions, we go into this disc space that's slipping. We take out a joint on the way there. It's called the facet joint. And we go in kind of a triangular direction. That's called a transforaminal lumbar route. And this procedure is called a TLIF, or transforaminal lumbar interbody fusion. And it can be done minimally invasive. And again, through those tiny incisions, we go through that joint, we take out the disc, we put in this type of expandable metal implant that reconstructs the disc space. It's filled with some bone to help the bone heal. And then we put in some screws and rods to stabilize this area. And one thing you might notice is where before surgery she was slipping forward, now she has really good alignment. The L4 is perfectly aligned with L5. She only stayed in the hospital 2 days and then was able to return home, where if this case had been done open, she likely would have had a much longer hospital stay. So how did she rate herself postoperatively? First of all, let's look at that overall health scale. She went from a preoperative scale of 40 to now she said she was 90 when she returned for her post-op visit, so she felt a lot better. Next, if we look at this pain scale, this is on a 10-point scale. 10 is the worst possible pain. Her back score goes from 5 down to 2, and her leg score went from 5 down to 0. So both of those numbers went significantly better. And then finally, this disability score also got much better. Again, preoperatively she was right around a 40, and postoperatively she's around a 10. So all of those numbers improved dramatically after a minimally invasive surgery. So let's do another example. This is an example of trauma. Washington has recently become a level 2 trauma center, so we are now seeing more of these type of patients in our community. And this is a type of patient who had a bone-forming condition called ankylosing spondylitis. This is also known as bamboo spine, because of the way that it appears on a X-ray or CT. And what is a result of this condition is the spine is more unstable for the same type of fracture that another person might have, because a lot of levels of the spine have fused by nature. So if you look at this person's spine, these bright white spots in the front, those are places where the spine fused to itself by nature. So it's acting like one long bone where all of these segments are connected. And then this patient had a trauma, and she has a fracture right here between T8 and T9. So this level has opened up, and that is actually unstable. She was very medically sick. She had atrial fibrillation, she took a blood thinner, she had had an aortic valve replacement, she had a pacemaker, she had chronic kidney disease, and now she had just had a motor vehicle accident. So there's a number of potential different treatment options. Some people might think of a brace because they think she's too sick for surgery. Some people might try to fuse this many levels from T6 to T11 open. MIS means minimally invasive spine. Some people would think of the same levels but minimally invasive. And then some might try to do fewer levels, either open or minimally invasive. Because she was medically sick, I wanted to try to do the smallest operation that could help her. And so I opted for option 5, the minimally invasive with the smallest number of segments that could stabilize her. So this is what that surgery looks like. It can actually also be done through a relatively small incision with very little movement of the underlying muscles. That's the important part for minimizing blood loss and for minimizing postoperative pain. So these x-rays are showing me putting in these screws right around her fracture. We use image guidance to make sure the screws are going in just the right spot, and they look very good. This is images from the operating table, and here's some postoperative images. And this patient did great, although she was medically high risk. And when you think of someone like this, you're worried, can they have a heart attack right after surgery? Can they have a stroke right after surgery? She had none of those, and she had a short hospital stay, recovered well, and was able to walk back to my clinic sometime later. All right, so now let's talk about another type of case. This is in the domain of tumors, and this is a spine tumor that was treated with a minimally invasive approach. This was a 77-year-old female patient. She had a history of chronic hepatitis B. She had a hepatic MRI that was done for a liver nodule that had been discovered some years ago. And then they also found something in her spine when they did that. And she told me she had been having intermittent low thoracic pain. Thoracic means mid-back, so intermittent low to mid-back pain, and started about a year ago. And of note, in her family, her dad had also had hepatocellular cancer. She had a normal exam. Her MRI looked like this. You can see this spot here, which looks different from the rest. And when we give contrast, that spot looks bright. That is a sign that there may be tumor inside of the vertebra at that level. And we can see the same thing a couple levels down, where there's this bright white spot, and at this level there's actually a compression fracture. So with an open approach, we would have to do a long incision, move the paraspinal muscles, but actually there's a minimally invasive approach that allows us to accomplish surgical goals with very tiny openings. So in this case, I did a very tiny incision at the upper level, inserted needles. I first biopsied to understand what exactly was happening in the spine, and then I inject this cement. And the cement is what you see as a dark black cloud or blob inside of the spine, and that actually gives some mechanical strength that can make a patient feel better. There was a randomized controlled trial for this too. This is called the CAFE trial, and it showed dramatically improved function for people with cancer and compression fractures from that when it goes to the spine. So what you see in this graph is the number of bed rest days that patients had. So this is people who got kyphoplasty. Red is how they were before the treatment. Blue is after. So they go from over 6 bed rest days to down to less than 2. Where in the control, if they did not get the kyphoplasty, they basically stay the same. So the patients are able to spend less time in bed and be more active. This is another graph showing the pain levels. And blue is the control, so these patients are not receiving the surgery. Their pain levels stay the same, 7 out of 10. And the patients who get the surgery, this kyphoplasty, which is a cement injection, their pain goes way down, and it's stable over time. So this is a very good minimally invasive option for some patients who have cancer that unfortunately has gone to the spine. Okay, lastly, I'd like to show you an example of a spinal deformity which was treated with a less invasive approach. Usually when we think of spinal deformities, we think of somebody who is somewhat crooked. They're either bending forward or to the side because they have some malalignment in their spine. This patient had actually already had a couple prior surgeries. When he met us, he was 66 years old. He had had an L1 to 3 fusion from the back and an L5 S1 fusion from the front and the back. And he said his back pain was disabling and he couldn't stand up straight. So previously, we used to do something very invasive for this, which is called a 3-column osteotomy. And this cartoon on the right is showing the concept where everything in gray is something that's removed in an open surgery for 3-column osteotomies. Basically, we're cutting out a big wedge of the spine, and then we effectively have to break the spine and put it back together to realign it. And in taking out that wedge, it causes a lot of blood loss, and often patients are in the hospital for a long time, and there's a lot of post-surgical pain. More recently, a different, less invasive option has been developed called anterior column realignment, and that is the picture you see at the bottom. And in this type of surgery, what we do, instead of taking out part of the spine, we actually go into the disc space, we take out some disc, we open a ligament called the anterior longitudinal ligament, and then we actually increase the length of the spine from the front by putting in this type of wedged implant that increases curvature, and that can help with alignment for patients. So this patient had that type of surgery. On day 1, we removed his old implants. On day 2, we did some surgeries from the side, including that type of anterior column realignment. On day 3, we did minimally invasive placement of new screws and rods. He did not have to go to the ICU like he would have with the old technique, and he was home on post-op day 3, which is actually pretty fast for this type of case. And his alignment was very good. You can see in this type of x-ray that he's now standing normally. I was part of a study group that looked at this, and we showed we were dramatically able to increase lumbar lordosis, or the sway in the low back that is needed to let one stand up straight. So preoperatively, you see in our cohort, we had patients with a very low lumbar lordosis that was only 18 degrees. And after doing this type of minimally invasive technique, we can increase by almost 30 degrees and get them into a more normal alignment. And that lasted at 1 year and at 2 years after surgery. Another benefit of minimally invasive surgery for spinal deformity is that blood loss can be much less. Here is an example from a different published paper showing that with minimally invasive cases, blood loss is less than 500 milliliters, where with the average open case, it was almost 3 liters. And almost all of those patients will need a blood transfusion. So this is a very nice technique for having patients have less blood loss and less in-hospital needs. So, in conclusion, that type of technique is a less invasive technique. It can correct that imbalance that patients have. Patients have less blood loss, and there's often also a cost reduction as a result of needing less things when they're in the hospital and potentially having a lower length of stay while they're in the hospital. Overall, for minimally invasive techniques, they can be used for a range of spinal conditions. That includes degenerative conditions, tumors, deformities, and trauma. They're associated with less blood loss, lower length of stay, lower cost, and we can achieve the same long-term outcomes that we could with the previous, more open techniques. Thank you for listening. I hope you were able to obtain some new information from this talk, and I'm happy to take some questions from the audience.
Thank you, Dr. Saigal. We do have a couple questions. The first one is, how do I tell if my back pain is due to muscle or my spine?
How can you tell if back pain is due to muscle or spine? Well, I would first say you don't have to tell per se, but if you have back pain, I would start by doing simple things. Take some rest, potentially take over-the-counter medications, Tylenol and ibuprofen. And when back pain persists for a long time, then it's time to see a professional. You may want to start with your primary care doctor. What are red flag signs that really necessitate a spine surgeon or spine specialist being involved would be the pain's not just in the back, but it's going down the legs. Or if a patient has not only pain, but they also have weakness in the legs, that's a red flag. Or sometimes in the worst case, if they have difficulty controlling their bladder or bowels associated with the back pain, that can be a sign that the sac of nerves called the thecal sac is very compressed, and that definitely requires evaluation by a professional. In the latter case, if you're having trouble using your bladder, that can even be a medical emergency where you have to go to the emergency room. But for simple back pain that, again, almost everyone feels at some point, start with simple things, rest, Tylenol, over-the-counter meds, and if that's not working, see your local doctor.
Okay, thank you. Our next and last question is, what can I do to minimize the risk for lower back pain or injury to my lower back?
Good question. What can one do to minimize the risk of low back pain? Well, simple things like staying healthy, trying to maintain a fairly normal weight. When we have too much weight, especially in our midsections, that can lead to an abnormal posture and put extra strain on the low back muscles. Similarly, ergonomics matter for the same reason. If we're always bending forward at work or when we're using our computer or our devices, that also can place extra strain on your low back muscles. So I encourage people to exercise, start with simple things, go for a walk, go to the gym, stretch, strengthen. Simple exercises can actually go a long way. And again, when one, in spite of good ergonomics, in spite of taking precautions at work, in spite of trying to stay healthy, if you have any of the triggers we talked about today, seek help from a professional, and here at UCSF Washington, we'd be happy to help you.
Thank you, Dr. Saigal, for this insightful presentation. This does conclude our program. And thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.